As Erica said, I'm Nicole Abdul-Bari, social worker with the Phoenix VA, and I'm just going to talk about assessing and managing suicide risk utilizing the therapeutic risk management risk stratification tool that the MIRC has come out with. But first off, I wanted to start out that I understand this is a very sensitive topic and that people in attendance may have had personal experiences involving suicide. So if you find you need to take a break or step away, please do so. And feel free to reach out to me at the end of the presentation if you need support, or if you find you need to talk to someone, call the National Suicide Prevention Line at 988. Press 1 for service members or veterans to connect to the Veteran Crisis Line. And thank you for joining me. I wanted to start off with a story that I actually heard recently, and it made me think of the work that I and my colleagues do here at the Phoenix VA in the suicide prevention team. And the story starts off with a man who went to visit his doctor for a general checkup. And the patient says to the doctor, "I want to ask you a question. I'm a multi-millionaire. I have 4 to 5 houses around the world, many cars, vacations all the time. I dress in the best of clothing and eat the best of food. But I am so stressed, and I always have that tension to the level that I have even thought of committing suicide." The doctor asked the patient, "What do you do if you want to please your eyes?" The patient said, "I look at natural scenery, a waterfall, a beautiful garden." And the doctor said, "What do you do if you want to please your nose?" "I smell a beautiful fragrance," the patient said. "What do you do if you want to please your ears?" asked the doctor. And the patient responded, "I listen to classical music." So the doctor says, "Is it possible that if you want to please your eyes, that you eat something delicious?" And the patient said, "No, of course not." And the doctor asked the patient why. And he said, "Because the tongue is not the tool that will give me joy in my vision, it's the eyes." And the doctor asked, "Is it possible if you want to please your eyes, you will hear music?" Again, the patient said no, because the ears are responsible for hearing. The doctor said, "Great. Now let me ask you a question. Where is the pain that you are talking about? Where do you feel it?" And the patient touched his heart and said, "Right here in my heart." So the doctor said, "So the pain is in your heart, and you are pleasing your eyes, your ears, and your tongue with your nose. You are not pleasing the right organ. Just like when I asked you if you want to please your eyes, you would not eat something delicious. So you are trying to cure one of the organs by pleasing other organs and ignoring what pleases this organ. So what is the tool of pleasing the heart? Everyone wants happiness, or just that sense of balance in life. No one would tell you they want to be miserable. Everyone's happiness is different. Wealth, children, being famous, spirituality, whatever that individual person's desires are. So our goal here with the suicide prevention team is helping the veteran find those resources, re-identify or identify what is important to each individual veteran and what each individual veteran identifies as their purpose, and helping them identify and refine that purpose through collaborative works with the veterans themselves, through VA and community providers to connect to those resources that will support the veteran back to that reconnection and finding that purpose and being able to cure their heart or that sense of purpose of living, so those thoughts of suicide go away. I would be happy to share that, so I can send that out later. So that was just one of the stories that I wanted to share that I have found really touching as well for the work we do. So next part, the objectives for today's session. I'm talking about the MIRC design and going through the different acuity risk levels We're going to go through safety planning, mental health treatment, and resources. So please feel free to ask questions that I will answer at the end of the session. And first off, I wanted to start off with looking at the tool. So I'm just going to bring that up real quick. So can everybody see the tool? So this is the therapeutic risk management risk stratification table. And we're going to go through the high acute, intermediate acute, and low acute risk. And then we're also looking at the chronic, and many of you probably have seen this before, but I just thought it's a good refresher to go through it again when we're working with veterans, intermediate, chronic, and low chronic risk. So first off, what is suicide risk assessment? The suicide risk assessment is a comprehensive assessment that determines what an individual's risk for suicide at any given point in time. It cannot predict the future, but therapeutic risk management is an essential part of good clinical care as it supports the patient's treatment and the therapeutic alliance, which we heard earlier is so important in the recovery model. Although tools are imperfect, most experts agree that a structured assessment, meaning a consistent way of assessing and integrating risk and protective factors, is more likely to elicit relevant patient information and produce consistent risk formulations. Additionally, several evidence-based suicide-specific treatments exist, including commonly available medications, increasingly available psychotherapies, and relatively simple multidisciplinary intervention. So while there's uncertainty about a patient's suicide risk, which might lead to conservative recommendations, using and documenting a risk assessment process educates patients about their risk while prioritizing autonomy and outpatient treatment. And it also creates an individualized care, effective communication with other providers, as well as the medical legal protection. The other aspect is the standard of care and suicide risk assessment is still with a thorough clinical evaluation. So the VA, across all the VAs, we use the comprehensive suicide risk evaluation. And as part of that, we utilize this tool to document the acuity of risk. So, and the important part of doing a structured evaluation is when we do unstructured clinical examinations, the free-form clinical interviews could potentially miss important aspects of risk or protective factors. So then just, I showed the MERIC design. So the risk stratification table that I just showed a couple minutes ago, that's from the Rocky Mountain MERIC, and which is part of the VA. And MERIC stands for Mental Illness Research, Education, and Clinical Center. And they have tons of information and resources that I will share at the end of this presentation. So next I'm going to move on to, we're going to look at the actual tool itself. So what is acuity? So the risk stratification table is looking at patients at risk for suicide. And it's a clinical, medical, and legally informed model for the assessment and management of suicide risk. It's designed to be used collaboratively with the patients you serve. The model has evolved to include flexible elements to meet each individual client's needs and clinical presentations. So to be able to optimize suicide risk assessment and management of that risk. So the original model involved three main components: augmentation of clinical risk assessment with structured instruments, also risk stratification with respect to both severity and temporality, and then collaborative development of safety plan. The model has also added the use of chain analysis to further explore the function of veterans' suicidal thoughts. Also looking at lethal means, safety guidance, and recommendations. The next part is obtaining collateral data for support persons in the veteran's life, if possible. I know we don't always have access to collateral input from veterans support system. And the next step is welfare checks as part of the therapeutic risk management. And the last one, post-pension planning and services for suicide loss survivors. So the next part. So now we're moving into the tool. So we're going to look at high acuity. First of all, what is acuity? Acuity is severity. High condition is severe and imminent danger in terms of looking at suicide risk. It requires higher levels of support and more intense levels of care supports. The essential features considered for high acute risk are plan for suicide, recent attempt or ongoing preparatory behaviors. Maybe they are experiencing symptoms, behaviors, having an acute psychosis, major depressive disorder, just weeks of symptoms of depression, acute mania, or recent or current substance relapse. Exacerbation of personality disorder could be another factor of common warning signs. So then other risk factors. So we're considering the warning signs and then risk factors. Common risk factors could be access to means, like what is their access to firearms, medications, have they been stockpiling the medications, as well as acute psychosocial stressors, job loss, relationship difficulties, breakups, divorces, or any relapses on alcohol, substance use. So then the next factor to consider is with high acute risk, looking at what's that intervention? What are our actions? Typically, high acute is requiring psychiatric hospitalization to maintain safety and aggressively target modifiable factors. Modifiable factors could be managing those symptoms, behaviors they're experiencing from the mental health diagnoses, depression. Maybe there needs to be a medication change with bipolar mania. Others, these individuals need to be directly observed until while they're on a secure unit and kept in an environment with limited access to lethal means, like keeping away from sharps, cords, firearms, toxic substances. And then during that hospitalization, co-occurring psychiatric symptoms would be addressed. Then we move on to intermediate acute risk. So again, we're looking at that severity, which for acute and for intermediate, the individuals may present similar to high acute risk, sharing many of the same features. The only difference may be lack of intent. Based upon an identified reason for living. Maybe they say they're the caregiver for their mother, father, other spouse, or their children, and they have the ability to abide by a safety plan and maintain their own safety outside of any external supports or help. And preparatory behaviors are absent. They haven't made any preparations to stockpile pills or get out their gun. The actions to consider would be maybe psychiatric hospitalization if there are related factor or risks that would be responsive to inpatient treatment, like acute psychosis, or outpatient management of suicidal thoughts or behaviors could be, and they should be intensive outpatient, frequent contact, regular reassessment of risk, and a well-articulated safety plan. And that mental health treatment would be addressing co-occurring psychiatric symptoms. So that was intermediate acute risk. Then we move on to low acute risk. So in low acute risk, generally there's no current suicidal ideation, but maybe they had been having some recently or in the past, but they have little or no intent and no specific or current plan. So if a plan is present, the plan is very general, vague, and without any associated preparatory behaviors. Like, example, I'd shoot myself if things got bad enough, but I don't have a gun and no plans to go buy a gun. So these patients would be capable of engaging in appropriate coping strategies. They're able to name coping strategies, and they're willing and able to utilize a safety plan in a crisis situation. So overall, level of individual risk may be increased or decreased based upon the warning signs that have been identified, risk factors, and protective factors. And looking at the protective factors that would mitigate those risk or warning factors. So actions to consider in low acute risk would be, can their crisis be managed in primary care? Outpatient mental health treatment may also be indicated if there are like psychiatric symptoms co-occurring. So that was the acute. So we looked at the acute, low acute risk, intermediate, and high acute risk. So now we're going to move on to the chronic. We're looking at chronic features. So the first part of high chronic risk is going to be looking at what is chronicity. So chronicity in itself is that it's like a fact or quality of being long lasting, like it's ongoing, and it influences on stress, can influence the severity or the chronicity, that chronic piece of illness. And with chronicity in terms of looking at suicide risk assessment is, are they having chronic suicidal thoughts? So individuals could be so individuals are at risk of chronic risk becoming suicidal. So actions, common warning signs, again, major mental health diagnoses, personality disorder, history of prior suicide attempts, history of substance use or dependence, chronic pain is very common, chronic medical conditions, having limited coping skills, unstable or turbulent psychosocial stressors, homeless or unstable housing, job loss or marginal employment, limited finances, erratic relationships, and just limited ability to identify reasons for living. Then we're looking at actions. What actions could we consider? Individuals at chronic risk are from becoming acutely suicidal, often in the context of unpredictable situations. So looking at what are their unpredictable situations. Again, looking at those psychosocial pieces. And generally, individuals would require routine mental health follow-up, a well-articulated safety plan, including name safety, no access to gun, are they locked up, can a friend have them? I know sometimes veterans say they don't have anywhere to store their firearm, working on a plan to maybe put it in a lockbox at an organization, a bank safe deposit box, or a pawn shop are some avenues that I have worked with veterans to have firearm safety storage. And then routine suicide risk screening, coping skills building, working with them to build their coping skills, and management of co-occurring psychiatric symptoms is important. So that's high chronic risk. Next, we move on to intermediate chronic risk. And looking at intermediate chronic risk, we're looking at individuals who often have similar chronicity as those of high chronic risk with respect to maybe psychiatric, substance use, medical, or painful conditions. But then looking at what are their psychosocial, what's going on with their risk factors, and their coping skills. What are their coping skills? So actions to consider when assessing individuals is, do they require routine mental health care to optimize psychiatric conditions, maintain enhanced coping skills, and maintaining or enhancing those protective factors, building those social connections, those relationships with family. And again, a well-articulated safety plan, including mean safety and ongoing management of any psychiatric co-occurring symptoms. And looking at those protective factors, those coping skills, reasons for living, is important in the intermediate chronic list as well. So the next part is, we're at the last one, low chronic risk. The low chronic risk. So with low chronic risk, many of the general risk factors are missing, like there's no history of self-directed violence, there's a lack of chronic suicidal ideation, no highly impulsive risky behaviors, or no history of that. Definitely we all change, circumstances change, so always considering that marginal psychosocial functioning. And then actions to consider, again, would be what is the appropriate level of mental health care as needed on an as needed basis. Some may be managed in primary care settings, others require mental health follow-up to continual successful treatment. Maybe referring to either community services or VA, like the psychosocial rehabilitation, the PRC recovery program could be options for actually all of our veterans with either high chronic, intermediate, or low, but it always depends on what's going to be best for the veteran. So the next part is, I just found a case example that I thought we could look through and go over to kind of look at the stratification tool. So we have a female 38-year-old with history of depression, reports loneliness, 2 to 3 weeks history of worsening depressive symptoms. She has her daughter, who is 3 years old, died approximately 5 years ago. She has 1 suicide attempt by overdose after the death of her daughter 5 years ago, and she was hospitalized after that overdose. Medical history, hypertension. She lives alone, reports many friends, works full-time as a banker, has a graduate degree, is reporting some financial difficulties, can't afford her car payments that she recently bought. Social alcohol use with increased, which her use has increased recently, and denies drug use. Parents are deceased. Father completed suicide when the patient was 8 years old, and mother died of cancer when she was 16 years old. So, mental status exam. She appears her stated age, thin, she's alert, cooperative, but tearful throughout the interview. Her speech is normal, her rate, tone, volume, everything within normal limits. Mood depressed, affect restricted, congruent with her mood. Her thoughts are linear. She's focused on wanting to leave and return to work. Reports, denies auditory visual hallucination, no overt delusions. She denies current suicidal ideation, denies homicidal ideation, and is reported to have future-oriented behaviors. So looking at that information, and through the interview that we would do with the veteran, we would gather some more information to help determine that risk, that level of risk. And looking at risk and protective factors for suicidal. What's modifiable? What's modifiable by treatment or non-modifiable? Some of the non-modifiable risk factors is the death of her parents, the death of her daughter. But what is modifiable? Her depression, possibly those feelings of loneliness with input, getting supports, building that support network with her friends, And then looking at whether or not are those risk factors, do they need to have inpatient psychiatric admission, or can they be managed outpatient? So an inpatient psychiatric admission is always the most severe or intrusive. Outpatient, looking at like getting them into services. So with the risk assessment, we do that thorough clinical evaluation, identifying those factors that increase or decrease their risk factors, and addressing the patient's immediate safety and determine the most appropriate setting for treatment. So it's important to remember suicide is not a diagnosis. It's not limited to depression, schizophrenia, bipolar, substance use, or personality disorder. And it's not limited to official psychiatric disorders. States of desperation, despair, impulsiveness, aggressiveness, disinhibited behaviors can all be factors towards suicide. So in terms of this person, I would say she is looking at low acute with intermediate or high chronic, because she's not saying that she has suicidal thoughts right now. She is reporting future oriented behaviors, some protective factors. But in terms of after assessing that risk, it's important to look at the next step. How can we support her? And the next step would be looking at the safety plan. And so we want to develop a safety plan. And the first step of a safety plan is looking at the warning signs. So a safety plan is a hierarchical list of coping strategies that can be utilized prior to or during a suicidal crisis. So prior to or during a crisis, a safety plan provides concrete steps that can be taken to navigate and survive a suicidal crisis. The development of a safety plan should take place following a thorough suicide risk assessment. A nuanced risk assessment informs the content of the safety plan, such as during the interview between the provider and the patient, a discussion likely took place of what those warning signs are, and those could be included in step 1. The safety planning is a brief intervention to help individuals survive suicidal crisis by having them develop a set of steps to reduce the likelihood of engaging in suicidal behaviors. Developing a safety plan is a collaborative effort, getting the input from the veterans on what works best, what are their warning signs, putting them in their words. What are their coping strategies and putting that in their words. A manualized version of the safety plan is available, and it includes the warning signs or triggers that indicate suicide ideation is about to occur or likely to occur, internal coping strategies, and the internal coping strategies are those strategies that the veteran can implement on their own without any outside support. Like, I've had many veterans say they'll read the Bible, they'll go for a walk, they will play video games or write poetry. So those could be some of those internal strategies that they could use to distract themselves and decrease those thoughts of suicide. The second part is looking at social contacts. Who could they reach out to talk about, just whatever's going on that could distract them, or places they could go, going to the park, going to church are a lot of times what veterans put down. And then looking at supportive contacts. Who could they talk to and reach out to in their own support network about like those suicidal thoughts that are having, or that they're in a crisis and they need help. And sometimes veterans just don't have anybody. And so then the goal in the treatment planning would be to develop those pieces. And then we put emergency resources. That could be ourselves as social workers, or the mental health treatment coordinator, or a community resource provider. Anyone who the veteran has a therapeutic or rapport with. And then we also put the local urgent care, emergency room, could be the VA hospital, it could be a hospital close to the veteran because the VA might be too far away. And then the last part is the safety of the home environment, reducing access to lethal means. So the safety plan at the VA, we asked them, is there anybody that can help the veteran with eliminating access or putting barriers in place so they don't have access, like a friend, family member, roommate, spouse, to like make sure the gun is not accessible or the medications aren't accessible. And then looking at reducing all access to lethal means and having that conversation. So that would be the safety plan. The next step is looking at mental health treatment. So there's several different treatment modalities, both like in the community and then through the VA. The VA focuses on these four treatment modalities that are research supported to help individuals with suicidal thoughts. Some examples: CBT, cognitive behavioral therapy, which helps veterans with suicide-related thoughts and behavior to understand the relationship among their thoughts, feelings, and behaviors, and to create new patterns of thinking to support positive feelings. The second one is DBT, dialectical behavior therapy. That therapy modality helps veterans with suicide-related thoughts and behaviors to address stress and strong emotions, learn mindfulness and distress tolerance, and develop practice and new interpersonal skills. And problem-solving therapy, the third one, is helping veterans recover from difficult situations and learn skills to improve their daily life. This therapy can improve one's ability to cope with major life circumstances and stressors and develop a response plan. The last one, safety planning intervention, helps veterans develop and maintain a sense of control when it comes to suicide-related thoughts and behaviors. The intervention will help learn coping strategies and find resources to keep safe during a suicidal crisis. And many of these, dialectical behavior therapy is another, like a referral for that, but through the cognitive behavioral therapy, problem solving therapy, safety planning intervention, the suicide prevention telehealth hub that we're a part of, Vision 22. They do the telehealth with veterans who have demonstrated either behaviors of suicide or attempts, and they will do the cognitive behavioral therapy. There's like 10 to 12 sessions, problem solving, safety planning, but whatever one modality is best for the veteran to help them develop those skills. The next portion of looking at the mental health treatment as providers, I found some tips from that veterans had shared for us providers to, it's important to be empathetic, use active listening skills, collaborate with the veterans, validate the emotions and thoughts that veterans are having. That's the key to the connection. And we're not judging, we're not correcting. And then also important to stay away from saying that you have so much to live for, or it's selfish to consider suicide because you have ... like friends, family, whatnot. So those are just some thoughts that I had found from veterans. So resources: Veteran Crisis Line, dialing 988, pressing 1, the chat, texting, and then we have suicideoutreach.org. We have the Military Crisis Line. We have Make the Connection, which is an online resource featuring hundreds of veterans telling their stories about how they overcame mental health challenges. And the Make the Connection is actually organized into the different periods of war eras. And then like Vietnam, there's veteran stories there, Gulf War. So they kind of organized it that way so it's easier for veterans to choose where they want to go. And then coaching and care. For providers, the MERIC, again, that Mental Illness Research Education Center, is a great resource For providers, they will do suicide risk management consultations with providers. It's free consultation support resources. They have webinars. So some of the webinars are included in this, and I can email those out to anybody who's interested. They have lecture series, and they have these different suicide risk assessment matters and all these webinars, and they also have lethal means safety. Then lastly, just suicide prevention team here at Phoenix and at all of the VAs. They every VA has a suicide prevention team, and all the coordinators are available if there's questions, or if there's a veteran you have questions about and you just want to ask some questions in terms of like what next, or if the veteran might need a high risk suicide flag on their medical chart, and you can always reach out to any of the coordinators. So that's all I have for today. And then I just referenced. Thank you very much.
Awesome. Thank you, Nicole. We really appreciate all the information you shared with us. It sounds like the best way to get in touch with you may be via email. Is that correct? If people had wanted directly to have questions or whatever after the summit, I could see it here. Okay, awesome.
And I'm gonna put that in the chat too.
Awesome. There was a question about whether or not you could provide the story that you shared. So I think that probably you could send it to me and I could send it out to the attendees. Is that?
Yes, yeah, definitely. Yeah.
Awesome.
That sounds good. Yeah.
If anybody has any other questions, please feel free to put it in the chat and I can ask them. Nicole. All right, we're getting feedback of thank you, great session. I'd like an email of anything you can send us from US Vets, an email from Banner Health, great story from Tony Black.
Well, thank you everybody for joining, and I will work on getting that information sent out. And I appreciate you attending today. You know, it's a lot of information, so, and it's pretty dry, so, but it's very important. So thank you very much.